Good morning, everyone, and thank you so much for joining us this morning for our webinar, Gestational Diabetes 101, a community cafe, hosted by the Office of Lifelong Learning Physician Learning Program and funded by the Canadian Institutes of Health Research. So I'd like first to take a moment to acknowledge that we are located on Treaty 6 territory, the traditional ancestral territory of the Cree, Dene, Blackfoot, Saulteaux, and Nakota Sioux, as well as being part of the Métis homeland. We acknowledge the many First Nations, Métis, and Inuit who have lived in and cared for these lands for generations. We are grateful for the knowledge keepers and the elders who are with us today and those who have gone before us. And we make this acknowledgement as an act of reconciliation and gratitude to those whose territory we reside on or visiting. I'm Dr. Rose Yeung. I'm the medical director of the Office of Lifelong Learning Physician Learning Program, and I'm also an endocrinologist. And I'm just going to go through a little bit of the housekeeping next. So please use the chat feature if you have a question about technical difficulties or L3 programs or services. If you have a question for the speakers, please use the Q&A feature of the webinar, and please review what has already been asked and upvote the questions that you would like answered. We can't guarantee we'll get to all the questions at the end, so please do vote for the ones that you'd like answered. So on that note, I am going to introduce Dr. Taniya Nagpal, who is one of the organizers, the main organizer of this event. So please do go ahead.
Thank you so much, Dr. Yeung. Hello, everybody, and welcome again. It gives me great pleasure to welcome you to our Community Cafe online this morning. And I have the pleasure of introducing our very first speaker. We have with us, We have with us Hildy Perez-Robie. Hildy came to Canada in 2008 as part of the pilot temporary foreign worker program. Currently, Hildy is working as administrative support at Multicultural Health Brokers, also part-time broker in the Rural Multicultural Supports Program under the Family Resource Network partnership with CIWA. She's a dedicated wife to a husband who fights MS daily. She's a mom to her kids, 12-year-old girl on the spectrum, and a cheeky little guy who is 9 turning 35. And we have the pleasure of welcoming Hildy today to share with us her story and experience with gestational diabetes. Hildy, over to you.
Thank you, Tanya. Good morning, everyone, and thank you for joining us. My name is Hildy. I would like to speak a little bit about my experience with gestational diabetes. It actually started with my first pregnancy with Diamond, who is now 12. When I was diagnosed with gestational diabetes, I didn't know anything about it. My mom, when she was pregnant with us, with the three of us in the Philippines, there was nothing spoken of about diabetes, gestational diabetes. It wasn't a thing back in the Philippines. And so when I was pregnant here, and they were telling me, oh, your sugar is high, you need to take this, you need to test every day, it was all foreign to me. I didn't know anything about it. They were trying their best. The diabetes clinic at the Grey Nuns was trying their best to educate me. They were making me attend classes weekly to teach me how to read labels, basically. And one other thing that I was having issues then was my pregnancy was complicated. I had what they called an incompetent cervix. So on top of having a complicated pregnancy, I was put on bed rest. They were telling me I need to get insulin almost 4 times a day. And then I need to buy my own supplies. I said, I can't afford that. I am on EI because I'm on bed rest. And they said, well, you can get benefits. I don't know what that is. I was a kitchen helper, and employee benefits was a foreign word to me, another foreign word to me. So I didn't know that I was eligible for any coverage whatsoever. And so I actually stopped using the insulin because the clinic gave me the insulin and they told me that it comes with a 6-pack of needles. And then after you use all of that up, you have to buy them on your own out of pocket. And you can't buy these needles in smaller batches. It's either a 50 or a 100, both of which I cannot afford. My husband cannot afford either. So I stopped using the insulin. I stopped testing, and I just let it go. So moving on to my second pregnancy, my son, he's 9 now. I didn't even bother getting tested. I knew if I had to go through that all over again, it would be so stressful to me. And so I just let it go. It's another complicated pregnancy. My OB-gynecologist at that time wasn't really concerned either. He knew that I had a history of gestational diabetes for the first pregnancy, but he didn't sound like he was overly concerned that I might have gestational diabetes for this second pregnancy. So he never asked me. I was never forced to take the test. He just let it go. So I didn't think that was important. I didn't mind it. It's another thing that I don't have to worry about because, again, I will be on EI and my work permit was expiring. So that's another thing that I cannot afford. I cannot afford this. So, in hindsight, now my daughter is 12. She has ASD. She was diagnosed when she was 4. When I was doing my research about autism spectrum disorder, I was getting a lot of information. And one of the things that one mom said, oh, it's because of the insulin that you were taking when you were pregnant. So I felt guilty. I kept thinking, did I do this to my child? Was it because of the insulin? Is that even related? Was it because I had gestational diabetes, that I was taking insulin, that my daughter is autistic now? Oh, yeah, it is. It is. Because you know what? You didn't take insulin for your second child, and he's neurotypical. And so for a time, I believed that to be true. I thought I did this to my child, taking so much insulin. But now my daughter's pediatrician is telling me, your daughter's insulin is high. She's obese. She's overweight. And then now I'm thinking again, did I do that to my child? Because I had gestational diabetes when I was pregnant with her. Did I do that to my child? So there was a lot of guilt put on me between being pregnant, dealing with gestational diabetes, and then the after effects. There was a lot of, did I do this to my child? Why is my first child different from my second child? Or is just because, well, I didn't know any better. I was not educated enough. So there was a lot of, I'm going to say there was a lot of guilt put on me. Perhaps I should have researched more about gestational diabetes, but I didn't have the time for that. I don't know if it's because I didn't want to learn, or I was in denial, or because, oh, they said it's going to go away after you're pregnant. After you give birth, it'll go away. So maybe, oh, we're okay. We're going to be okay. But now I too am type 2 diabetic. So did that have anything to do with it? Because I wasn't taking care of myself when I was pregnant. So now I have type 2 diabetes and I am on insulin weekly. I have so many questions and I don't know if I'll ever get any answers. And it's really difficult to be a foreign worker and not having coverage, not having work benefits, and having to pay out of pocket for lancets and strips and needles. I mean, I understand that the clinic will give you samples of insulin, but that'll only go so far. And then there's that pressure of having that guilt. Did I do this to my child? There was just so many things that I wish I knew better. I wish I was educated more when I was pregnant. And I wish the Alberta Health Services would push a little bit more education. Maybe my daughter would have been different. Maybe she's okay. Maybe I would have been okay. But again, those are questions that I may never know the answer to. So in closing, I would just like to say that it's nobody's fault. I would like to think that it's not my fault. It just is. It's a matter of taking care of yourself, the diet. Oh, by the way, I am Asian. So rice is life for an Asian woman. And so when you are told you're only eating this much rice, or you can have a toast and some peanut butter, that's not enough for me. I need rice every day, 3 times a day. So that's another challenge that I was thinking of. But yes, in hindsight, I wish I knew better. I wish I was educated better. Maybe things could have been different, but I would never, I'll never know now. And thank you for listening.
Thank you so much, Hildy. And I just wanted to say it's not your fault. If anybody has questions for Hildy, you can put them in the chat, but we will get to questions at the end, and any comments you'd like to share as well in the chat. But thank you so much, Hildy, for sharing your story with us, and yeah, the challenges that you faced as and the lessons that you've shared with us are so valuable and meaningful to share with the audience. So thank you so much for opening our cafe today. And with that, I'm going to welcome back Dr. Rose Yeung. As Dr. Yeung mentioned, she's an associate professor of endocrinology at the University of Alberta, and her research focuses on diabetes in pregnancy and co-creating better systems of care for people living with diabetes. She works at the K Diabetes and the Royal Alex Diabetes in pregnancy clinics. Dr. Yeung.
Thanks very much. So I'm just going to share my screen here, and hopefully this works. And I've got a little video for you as well. Oops. Okay. So I'm going to give a little bit of the what and why. And yes, I also want to thank Hildy for that touching story, because this is what I see day in, day out in clinic, is women coming during a very, emotional time of life during pregnancy, and then having to deal with the blood sugars on top of the emotional and physical roller coaster of pregnancy as it is. So just to give us some grounding about what diabetes in pregnancy is and what gestational diabetes specifically is we generally categorize diabetes in pregnancy into 2 things: pre-existing diabetes, so people with pre-existing type 1 or type 2 diabetes. That is not what we're talking about today. Today, we're going to focus on gestational diabetes, which is the diabetes first diagnosed in pregnancy, primarily due to the hormones of pregnancy, but we're also going to talk about some of the other risk factors that lead people to develop gestational diabetes. And the reason why we care about gestational diabetes particular is that we are seeing huge increases in the rates of gestational diabetes. And this is Alberta data. So I'm also a researcher, and I do this population-based research. And we've seen that close to 10% of deliveries in Alberta, and increasing, are now affected by gestational diabetes. So my group has created a website called diabetes-pregnancy.ca, and we'll be, to all the registrants, we will be sending out a summary information with some of the resources to the email that you've registered with. But we made a video in conjunction with people living with gestational diabetes, as well as healthcare professionals in the space, And this is a little bit of an explanation. So let me just share this screen.
Gestational diabetes shows up in many different women during pregnancy and occurs in up to 6% of all pregnancies in Canada. This is a temporary type of diabetes that occurs during pregnancy. There are certain factors that can put you more at risk for having GDM, such as being over 35, having an increased weight, non-white ethnicity, polycystic ovarian syndrome, certain medications, having a previous pregnancy with gestational diabetes or a large baby, or having a family member with diabetes. So what happens? When you eat carbohydrates, they are broken down in your gut into sugars and are transported into your bloodstream to provide fuel for your body. When these sugars enter your bloodstream, we call it blood glucose or blood sugars. These sugars travel to all the different organs and tissues to be used as energy or stored for later use. In order to move the sugar from the bloodstream into your body tissues like muscle, a special hormone called insulin is needed. Insulin is produced in the organ called the pancreas. Insulin is like a key that opens the door to the muscle cells to allow the blood sugar to enter and be used as fuel. Without enough insulin, the sugar is stuck in the bloodstream and can build up. This is called hyperglycemia, also known as raised blood sugars. When the blood sugars are too high for an extended period of time, we call it diabetes. During pregnancy, the placenta in the uterus makes sure your baby has the nutrients and oxygen it needs, so it produces some other hormones that help to ensure the blood sugars are high enough. In gestational diabetes, something goes wonky and these hormones are working too hard and actually cause the blood sugar to rise too much. As pregnancy progresses and the hormones get stronger, women with gestational diabetes often require increasing doses of insulin to counteract these hormones. The good news is there are several ways we can help our body manage gestational diabetes. The first step is creating a plan with your healthcare team that will focus on healthy eating and physical activity. By the end of your gestational diabetes journey, you will have the tools and knowledge you need to raise a healthy family.
Just getting back to the other screen. Okay. So that gives you a little bit of the background towards what causes gestational diabetes. And this drawing just shows that one of the biggest effects on the baby that we're concerned about is that those high blood sugar levels in the mother pass through the placenta and are bringing too much sugar to the baby, and the baby grows too quickly and can put on too much weight. That's the biggest risk factor, or that's the biggest risk to the fetus while they're exposed to this high blood sugar, is growing too quickly and then having complications. So how do we diagnose gestational diabetes in Canada? So there are two ways that we can diagnose gestational diabetes, but generally speaking, all pregnant women should be screened between 24 and 28 weeks gestation or earlier if they have a high risk of gestational diabetes based on the risk factors that were mentioned in the video, and I'll show you another slide with that. And so many people go through something called a 50-gram glucose challenge, where they are asked to drink 50 grams of a sugary solution, and then they have their blood sugar tested 1 hour later. And then based on the thresholds of that blood sugar 1 hour later, they either are cleared or they go on to be diagnosed with gestational diabetes. For those in the intermediate, they go on to have a 75-gram oral glucose tolerance test, which is 75 grams of a sugary drink. And this is shown on this side, where people will get the 75-gram drink, and they will have blood testing before they have the drink, 1 hour after they have the drink, and 2 hours after they have the drink. And if any of those values are high, then a diagnosis of gestational diabetes is made. And so most women in Alberta go through the 50-gram first, but for people who are very high risk and who have multiple risk factors, I do advise getting the 75-gram test off the bat, because what we have found is that actually this fasting blood sugar level is actually very predictive of whether the baby is going to be bigger or whether you're going to have problems with blood sugars. So a fasting blood sugar is very helpful, whereas it's missing from the 50-gram test. So long and short of it, please ask your doctor or healthcare team if you need earlier gestational diabetes screening if you have more than one of these risk factors, that being previous diagnosis of gestational diabetes, older age, if you have overweight or living with obesity, if somebody's told you you have prediabetes or polycystic ovarian syndrome, if you have parents or siblings with type 2 diabetes or gestational diabetes, if the baby is already measuring too large or has too much fluid around them in the uterus, and if you've given birth to a large baby, more than 4 kilograms, that's 8 pounds or 13 ounces or more, or if you're using certain medications that can cause elevation in sugar, like prednisone or dexamethasone, these factors can all put you at higher risk. And if you have multiple of these, then certainly I would be advising to go straight to the 75-gram test in the first trimester, and even pregnancy planning to let your doctor know that you're thinking about pregnancy or thinking about pregnancy in the future, and to have a conversation to make sure that you're looking at what you can do to try to reduce your risk. A physical finding that some people may have is something called acanthosis. And this is darkening of the neck or the armpits. And sometimes it's also associated with some skin tags. And if you see this on yourself or a family member, this could be a sign of prediabetes or diabetes. So this is definitely, if you see this in your family or in yourself, you must get your blood sugars checked. Some pregnant women just have this and do not have diabetes, but it is important to have the blood sugars checked if this is happening to you. So the risk to the mom. So as I mentioned, the baby can grow too large, and then the problem is physically getting the baby out safely. So moms can have more trauma from these larger babies and higher need for C-section, as well as the stressor of having the baby and having high sugars, and the disturbance in the metabolism from the high sugar can put people at risk of pregnancy-induced high blood pressure. And in severe cases, they can be at risk of something called preeclampsia and eclampsia, which is high blood pressure with multiple organ damage, including headaches, which can progress to seizures, liver damage, kidney damage, bleeding, and stroke. So it is a very serious condition that we want to make sure that women are being monitored for, and that we can do everything that we can to prevent this from happening. And unfortunately, once someone has a diagnosis of gestational diabetes, it's a bit like a canary in a coal mine. It's a warning that under stress, like pregnancy, the body cannot manage as well. And so that longer term risk, women are at much higher risk of type 2 diabetes, where up to 70% of women with a history of gestational diabetes will develop type 2 diabetes by the age of 80. And this is important to know because you're at higher risk, but this means that there are ways that you can modify and reduce that risk in the long term, focusing on physical activity, nutrition, and the right medications, as we'll get to throughout this talk today. Women are also 2 to 3 times higher risk of developing high blood pressure and heart disease, and having obesity later on post pregnancy. When it comes to the baby, we are concerned about the baby growing too large and then getting stuck in the birth canal. So if the baby gets stuck, they can dislocate their shoulder. They can get nerve injury from the nerves between their head and their neck because they're having difficulty getting out of the birth canal. And in extreme cases, if the baby gets stuck and something happens with the cord, they're at risk of brain injury. So we really do want to make sure that we're trying to modify the rate of growth if gestational diabetes is present. But ultimately, if the rate of growth is high, then the obstetrician is going to schedule a C-section. One of the other things is that because the baby gets so used to a high level of blood sugar in the womb, the baby starts actually making insulin because its pancreas starts working in the later trimesters. And so it's already handling the high blood sugars with its own pancreas. But then when the baby comes out and there's no more high blood sugar going into the baby from mom's through the umbilical cord, that extra insulin the baby's produced to deal with it suddenly causes the baby to have low blood sugars because they've been used to the high sugar environment, and suddenly that's cut off when the cord is clamped. So babies are at higher risk of developing hypoglycemia or low blood sugar after birth. These babies are also at higher risk of prematurity, immature lungs, jaundice, need for NICU, and when not managed, stillbirth. So they're very serious outcomes that can affect the baby if the diabetes is not managed properly. And in the longer term, unfortunately, those babies' genes, the baby's genes are mom's genes, and mom's genes are programmed for higher rates of type 2 diabetes in the long term. And we've even seen things like premature puberty in girls from exposure to gestational diabetes in the womb. The good news of all this is that treatment reduces the risk of complications. So when Hildy was talking about feeling guilty about using insulin and the insulin causing autism, I can 100% say that this is a myth. Insulin does not cause autism. Insulin does not cause complications. The complications come from uncontrolled blood sugars and the derangement of the metabolism that the baby is growing in. So what we want to do is we want to treat the high blood sugars appropriately. And we usually do that as a team with a doctor, a nurse, a dietitian. And we ask women to test blood sugars 4 times a day before meals, before breakfast and after the meals. And then get people educated on how to eat healthily and encourage physical activity, and give these glucose targets to meet to try to keep the blood sugars in a safe range. And in Alberta, what we know is about 1/3 of women who have gestational diabetes require medicine. So that means 2/3 of women with gestational diabetes can actually manage reasonably well with physical activity and nutrition alone. And the first line medication that we use is insulin. And that is because it is tried and true. We've used it for decades. We know it's safe. Metformin, which is a pill that works at the liver to stop the liver from making sugar, is gaining popularity, but it has not been approved in Canada for use in pregnancy yet. We know it crosses the placenta. We don't have a lot of long-term data on it. But this would be second-line therapy, and another medication called glyburide is also considered okay if women can't take the insulin. But really, insulin is preferred. And if people are on insulin, I would advise you to check out our site. There is a great video on Will I Need Insulin and the implications of that, but I just don't have time to show it for you today. So after delivery, one of the things that we encourage women to think about, and actually even before, delivery, want to encourage people to prepare for breastfeeding if that's something that aligns with their values, because we know that breastfeeding will reduce the future risk of type 2 diabetes for women. And it also reduces neonatal hypoglycemia rates, childhood obesity, and diabetes rates. So it's a really important thing to consider. So it's not just good for the baby, it's good for the mom. And then we also want to make sure that once women have a diagnosis of gestational diabetes, they get proper follow-up. So you need to repeat that 75-gram drink. And I know it's a pain. It's a 3-hour test. I know it's aggravating and hard to, arrange after you've just had a baby, but it's really important that you've gotten this done to make sure the diabetes has cleared and gone away. And then thereafter, it's important for women to have yearly diabetes screening with the family doctor or the primary care team and discuss any plans for future pregnancies. because we certainly want to make sure that the diabetes doesn't creep up and that women, so busy taking care of the family, neglect themselves and then show up with diabetes complications a few years later. So it's really important to follow up and make sure that the testing is happening regularly. And just a couple words on breastfeeding to avoid future type 2 diabetes. Breastfeeding actually reduces the risk of type 2 diabetes by around 30%. And we know that the longer and the more that people breastfeed, that further reduces the risk of future type 2 diabetes. And there's something called the power hour. So, a lot of patients will say, well, I want to breastfeed, but I don't know how, or I had a bad experience in my past pregnancy. I want to give people 2 quick tips on how to really more effectively prepare for breastfeeding. So when the baby is born, the brain needs the immediate signal that the baby is alive and looking for food. Otherwise, if the brain doesn't get that signal immediately, it's going to turn off milk production because it wants to convert all the energy in the body to save the mom from the trauma of having given birth. So, you think back to evolution and you think back, to, a century ago when medical care wasn't as great. If the baby wasn't alive, the body would just preserve mom. So you want to give your body the signal that the baby is doing well, immediate or looking for food as soon as the placenta is delivered. And so you do that by putting the baby immediately skin to skin and offering the breast so that the body knows the baby is alive. If for whatever reason there is separation or the baby can't, doesn't have the wherewithal to feed because it's just gone through birth and is too tired, then what you do is you stimulate the breast and do hand expression of the milk or colostrum immediately. The other thing people can do, and this has been this has been proven in gestational diabetes to be an effective means of promoting breastfeeding, is something called prenatal colostrum expression, which is basically starting to milk the breasts at 36 weeks and give yourself a chance to wake up the milk cells before the baby is born. And there is much more information at this site called moremilksooner.com. You can get colostrum prenatal expression kits there and videos and a lot more information. So this is just a slide showing you that first hour after birth is critical to telling the brain and the body that the baby needs milk. So for example, within an hour, if people started breast milk expression within an hour, on day 1, they produce 7 mils. If it's more than 6 hours or even between 1 and 6 hours, look at the difference on day 1. 7 mils versus barely anything versus 0 mils. Now, as time goes on, if people are persistent, the milk will come in. It just comes in at less rate. So by a week, within 1 hour, you can see there are 306 mils of milk versus, just above half that versus less than half that at 7 days. So that signal in that first hour makes a big difference. And I hope that families recognize that and can support that. And also for the partners out there, if your wife or if your spouse is too tired and can't express, then maybe that's your job, is to help massage and help get the milk out as part of the birth plan. So there are reasons why people should not do prenatal colostrum expression at 36 weeks. So if people are have threatened or preterm labor, have a short cervix, have placenta previa, or risk of bleeding, these would be reasons why you should not be doing this. But it is always a very good idea to speak with your obstetrician or whoever is helping you deliver, your midwife, to talk about whether you are a good candidate for prenatal colostrum expression. So please check out the websites, diabetes-pregnancy.ca for more info, and moremilksooner.com if you're interested in breastfeeding. And with that, I will end there and pass it on to the next speaker.
Thank you so much, Dr. Yeung. And as a reminder, if you have any questions for Dr. Yeung, you can put them into the question. And the next speaker is actually myself, so I will share my screen. All right. So hello, everyone. Again, as mentioned earlier, my name is Taniya Nagpal. I'm an assistant professor at the University of Alberta in the Faculty of Kinesiology, Sport and Recreation. And I will be chatting briefly with you about gestational diabetes and exercise. So I'm going to go over why it's important to be physically active during your pregnancy, what are some safe exercises to perform during pregnancy, and additional measures or cautions you should take if you're exercising with gestational diabetes. So why exercise during pregnancy? We did a massive study where we took a look at 18,000 studies from around the world that have tested various types of exercise and physical activity interventions during pregnancy. And what we found is that being physically active throughout pregnancy has several benefits for both mom and growing baby. And one of those benefits is reducing the risk of gestational diabetes by up to 40%. And so this study, if you were interested in learning more particularly about those guidelines, I've got the QR code there for you. In addition to gestational diabetes, we found that being physically active throughout pregnancy had other benefits like reducing the risk of hypertensive disorders, postpartum depression, as well as reducing things like prenatal anxiety, and again, up to 20 to 40% reduction. So we saw that physical activity carries many benefits throughout the pregnancy. And there's always the question, well, what about baby? Is physical activity potentially harmful for the growing baby? And that ends up being often why many individuals might choose to not be physically active. So with those 18,000 studies, we also tried to identify, does being physically active increase potential harms to baby? And what we found is that it does not. It does not increase risk for fetal harm. So it doesn't increase your risk of miscarriage or spontaneous delivery. It does not increase your risk of baby being born too small. And those are usually the concerns that individuals have expressed, that if I'm too active, does that mean I'm taking nutrients away from baby? And what we found is that that does not happen with physical activity. So overall, we could conclude that being physically active is indeed important for both mom and growing baby. And I've got some pictures on the screen here of some popular activities that a lot of individuals share they enjoy doing pregnancy, such as doing yoga, some body weight exercises, swimming, which can take a lot of the pressure off the weight that you might be feeling with the growing baby, as well as just going for a walk. So when I keep saying being physically active, how much is enough, or how much is the amount that's actually recommended? So ideally, we want pregnant individuals to aim for 150 minutes of activity throughout the week, which not all done in one day, but broken up throughout your week. So aiming for 3 to 5 days where you're trying to be active for at least 30 minutes per day. And when we think about how that activity should feel, if you think of a scale from 1 to 20, where 1 is doing absolutely nothing, you're sitting and you're not tired at all, to 20 being very, very, very hard, you want to be somewhere in that middle zone of fairly light or somewhat hard. And so that might mean that while you're exercising, you're able to still carry a conversation. That's a way that you could assess, am I working out hard enough? So you're still able to carry a conversation, but you might not necessarily be able to sing a song. Or if you've got a heart rate monitor on, you could see that your heart rate is increasing, but you're still in that fairly light and somewhat hard zone. In addition to some of the activities I presented earlier, we see that there are several safe exercises to perform while you're pregnant. So going for a walk, swimming, yoga, even light resistance training. It doesn't have to be heavy weightlifting. So some of the images there are showing you examples of some light resistance training where you could use bands to do some muscle exercises, even seated exercises, depending on if you're experiencing any back pain. Aerobic classes during pregnancy are quite popular and are also available through community resources in many communities, such as in the Edmonton community. If you're somebody who likes to cycle, you might switch to stationary cycling. And I want to highlight that being physically active might be chasing after your toddlers or doing things around the house as well. So if I go back here, sometimes the activities that we're doing day to day actually get us into that fairly light and somewhat hard zone. But they're not those traditional activities that we do at the gym or those activities that look like this, where we put on our fitness gear and are doing that dedicated time. And that's okay. You might just find that going for a walk with your dog, chasing your toddlers, doing things around the house or at work might give you enough physical activity for that day, and that may be sufficient. The goal is to try to aim for at least some level of light to moderate activity, 30 minutes every day. So what do we know about physical activity if you already have gestational diabetes? So I was talking earlier that being physically active can reduce your risk and help you prevent gestational diabetes. But what if you already have gestational diabetes? And with that large study that I mentioned, with those 18,000 papers, we actually did a sub-analysis. So we looked at just the papers that focused in on pregnant individuals who already had gestational diabetes. And what we actually found was those guidelines that I presented to you are also safe for individuals who have controlled gestational diabetes. And so when I say control, as Dr. Yeung mentioned, 2/3 of women likely will not necessarily need to use medical intervention. So they have controlled diabetes with things like their diet and exercise. So for that group, it is safe to be physically active. But also, if you are put on medication, you can consult with your doctor. If you're managing your diabetes, even with medication like insulin, you could still be physically active. So those same guidelines of aiming to have at least 30 minutes of activity per week are safe for individuals who have controlled gestational diabetes. With that group, we found that there's no increased risk of complications to mom or baby and no worsening of gestational diabetes-related symptoms. In fact, we've seen in some studies that if you were prescribed insulin to control your gestational diabetes, you could actually potentially have a reduced dose of insulin being prescribed if you're physically active. As well, if you need to monitor your blood sugars immediately after a meal, going for just a 10 to 15-minute walk can help reduce those blood sugars. And it can also improve newborn outcomes. So again, Dr. Yeung mentioned that one of the concerns with gestational diabetes is that babies might be born too large. And if you have gestational diabetes and you engage in physical activity, this is an effective way to try and prevent that. So with physical activity, we improve the nutrient transfer that moms have to their baby, and this can help us prevent babies being born too big. Now, of course, you want to add some additional safety measures when you're thinking about being physically active with gestational diabetes. So some of those safety measures might be you want to monitor your blood sugars before an exercise session. So if they're too low, you might want to have a snack and wait before you start your session, as well as after an exercise session and having a snack on hand or beverage because we don't want those sugars to drop too low. If you're feeling lightheaded, you need to stop the activity that you are doing, and you need to make sure you're staying hydrated before, during, and after activities. And I want to emphasize that you can modify your activities based on how you feel even that day. So it might be one day you're going for a walk, and another day you don't feel like doing as long of a walk, as fast as a walk, or maybe you need to do some different exercises depending on how your body's feeling that day. If you're nervous about being active during pregnancy, whether you have gestational diabetes or you don't, that is completely normal. Most pregnant individuals can do whatever activities they were doing before their pregnancy and just modify them. But oftentimes we're just nervous about, is this going to harm baby? And like I said, those guidelines have shown that they don't necessarily harm baby. But you need to remember that physical activity should never feel forced. You should never feel, I've got to hit my 30-minute right now. Instead, you need to listen to your body and engage in activities that you're comfortable doing and also enjoy doing. Consult your healthcare provider if you do have any concerns about being physically active. You can always check in with them and confirm if it's okay for you to engage in physical activity. You can share with them what activities you're interested in doing, and they can confirm if those are safe for you to participate in. Keep in mind that pregnancy is not a time to start a brand new exercise routine or try something that you find particularly tough and challenging. Rather, like I said, you can probably modify what you were doing before, or if you weren't active before, you can start at a lighter intensity, even lower than somewhat hard, and build up as you feel comfortable. And remember, consider your daily activities. You can do exercise at home. It doesn't have to be something that happens at a gym. It doesn't have to be something that requires a ton of exercise equipment. At the same time, you might want to join group activities and supervised opportunities. That's also a great way to meet other pregnant individuals in the community. And then finally, exercise should not hold guilt. So if you have a day where you skipped exercise, that's okay. Know that things change every single day, and that's okay. The activities you feel like doing each day might change as well. And with that, I'd like to thank you, and I look forward to answering your questions. And at the same time, I'm going to pass it on to our next speaker. So going from exercise now over to nutrition. So welcoming Emily Fleming, who is a registered dietitian who graduated from the University of Alberta in the Nutrition and Food Sciences Department in 2018. She became a dietitian believing nutrition education should be practical, easy to understand, and accessible. She has primarily worked in chronic disease management and has experience in rural and urban healthcare settings. When working in rural centers, she supported many pregnant females managing gestational diabetes between visits to the Edmonton Diabetes Clinic. And Emily is currently completing her Master of Public Health with the University of Alberta and will graduate in spring 2024. During this time, she has worked as a research coordinator at the Women and Children's Health Research Institute and as a research assistant in applied policy research with the CARE Lab at the School of Public Health. Over to you, Emily.
Awesome. Thank you. So today I'll be talking about healthy eating for your blood sugars when you have gestational diabetes. Perfect. So in Alberta, as Dr. Yeung mentioned, if you find out you have gestational diabetes, you will get referred to a diabetes clinic for support, where you should be receiving support from a dietitian, a nurse, and a full healthcare team. However, sometimes it can take some time until that appointment is made. So the best time to make changes to your diet is right when you find out. So that's what I'm trying to help you with today. And then also, our recommendations today are safe for everyone. So this is helpful nutrition recommendations for anyone that's kind of living healthy, whether you're pregnant or not, or that any pregnant person can follow. So why eat healthy if you have high blood sugars? So if you have high blood sugars during pregnancy, a healthy diet can help maintain a healthy body weight, help baby grow healthy so baby doesn't become too big, and prevent some of those pregnancy-related complications that Dr. Yeung mentioned. So today I'll be talking to you about 5 recommendations for healthy eating if you have high blood sugars. So we'll first talk about meal spacing. We'll talk about carbohydrate foods, which are foods that increase your blood sugars. We'll review what balanced meals can look like, healthy snacks, and healthy drinks. So first, let's look at meal spacing. So when I say meal spacing, I'm referring to the number of meals and snacks you eat throughout the day, as well as how often you're eating. So the first thing that we want to think about is trying to eat 3 meals and 2 to 3 snacks every day, and try not to go more than 4 to 6 hours between eating. This keeps your blood sugar from going too low or too high. Now, one of the reasons we want to eat regularly is that we're trying not to get big spikes in our blood sugars. So you'll see here on the graph that between those 2 red lines, that is what we call like a healthy blood sugar range. So when we're eating regularly, we're getting normal increases in our blood sugar, which is normal after we eat. Everybody should be getting an increase in blood sugar. We just don't want it to go too high. So you'll see this is a meal pattern where someone's eating about 3 meals and 3 snacks, and they're not going too long between eating. Because one of the risks that happens when we miss meals, we'll look at this next slide here, is that when people go really long periods between eating. So let's say this is a person that wakes up, maybe they're not really feeling hungry or they're distracted. They're not really noticing their body's cues. And let's say at like 3 o'clock, they go, oh my goodness, I'm really, really hungry. They may eat more than their body needs. So they see a big spike in their blood sugar. And then let's say they're not really full. So they eat again quickly. So then the blood sugar doesn't have enough time to come down between meals. It goes even higher. So this is an example of what can happen when we don't eat frequently enough throughout the day. We may eat more than we need, more of those carbohydrate-rich foods. So this is what we want to avoid. So you keep hearing me refer to carbohydrate foods, but now we'll talk about what they are. So carbohydrate foods have sugar and starch in them, which turn into blood sugar after you eat. And something I hear when people come to me, they say, oh, I can't eat any carbohydrates anymore. And that is not what we want you to do. So carbohydrates are good for our body when we choose certain types and certain amounts. They give energy and nutrients for your baby to grow healthy. They help you manage your blood sugars. And keep in mind that some carbohydrates are better for our blood sugars than others and should be chosen most often. So let's look at what those foods are. So these are just some examples. The carbohydrate foods that we want to choose are ones that are high in fiber. So you'll see here on the screen, we have whole wheat naan or roti, parboiled rice instead of white rice, lentils, injera made with teff flour, plantain, oatmeal, or any whole grain cereal or whole grain pasta, and then fruit. So these carbohydrates have something called fiber in them. And what fiber does is it slows down how quickly our blood sugar rises after we eat. So at those 3 meals and 2 to 3 snacks throughout the day, it's totally okay to choose a carbohydrate food. And we'll talk about the portion to have later to give you the best bet to manage your blood sugars. Now, the carbohydrates we really want to limit. So if we have these, we want to have small amounts and really try to limit them to kind of as infrequently as possible. These are candy, dessert, or ice cream, cookies, cakes, chips, chocolate, and sorry, the bottom should say fruit juice instead of fruit. So fruit is still okay. Fruit juice we want to limit. And the reason being is that they don't have any fiber. So that fiber is what keeps our blood sugars from going too high, but they also have a lot of free sugar. And that added sugar can cause big spikes in our blood sugars, especially when eaten without any other foods. So you'll see on the bottom right screen, I put unless. So there are some times where we may want some of these quick acting sugars. Especially if you're taking insulin when you have gestational diabetes, you are at higher risk for a low blood sugar. So if you find that you're feeling sweaty, trembling, anxiety, palpitations, any of those symptoms on the screen, you really want to test your blood sugar. If it's below 4, then we need to have, oh, it didn't come on the screen there. Oh, perfect. Some of that quick acting sugar. So this can look like any of the foods on the screen. So some juice, some candy, a tablespoon of sugar and water. Your diabetes nurse or your dietitian will tell you all about this, but we want to have that really quick acting sugar because if our blood sugar is low, that can cause us risk right now. And then after that, people tend to test their blood sugar again, and they repeat those steps until it comes back to normal. So one kind of thing I have on this screen when it comes to the carbohydrate foods, it says, what if I take insulin? So something to know is that you may need to measure how many carbohydrates you eat more closely if you're taking insulin, but a dietitian or a nurse will help you with that because it's just out of the scope for our presentation today to talk about counting those carbohydrates. So my third tip I have here is now we're going to kind of zoom back out and talk about balanced meals. So we talked about carbohydrates. We talked about how many meals we should have in a day, but what should we actually include in those meals to balance our blood sugars? So at each of those 3 meals, we want to try to kind of follow this plate method on the right, and I'll show you some examples in a minute. But we want our plate to be about a half plate vegetables or fruits because that has that fiber that we're looking for. We want about 1/4 of our plate or 1 to 2 fists to be those carbohydrate foods. And we want to choose those whole grains. We talk about whole grain pasta, roti, bread, parboiled rice, oatmeal, and then about 1/4 of the plate to be protein foods. So we'll go through protein foods in a bit more detail because there's something that we should know, which is that protein foods, the reason that we're having them is that they also help slow how fast our blood sugar increases after we eat. So protein foods include things like lean meat, tofu, paneer, eggs, tuna, poultry, nuts and seeds, and the other options on the screen. These are the ones we want to choose more often because they're high in protein and low in fat. And when you take those protein foods and you pair them with carbohydrate foods, that creates that nice balance to keep our blood sugar from going too high after we eat, because it slows digestion and it helps us feel full. And before we get into some examples of what those meals can look like, the one thing I want you to know about vegetables is that we can have them many different ways. So you can have them raw, you can have frozen vegetables, you can cook them, maybe roasting or steaming without too much added fat, and even canned green beans or other canned vegetables. These are all okay. It's important to choose foods that are accessible for you based on your lifestyle and your budget, and not feel like it has to look a very particular way in order to eat healthy. So we'll look at a few examples here. A balanced meal can look like having a half plate of some vegetables or pico de gallo with some guacamole. For your protein, you could have some stir-fried chicken there. And for your carbohydrates here, you see that the person chose some black beans and a corn tortilla. Balanced meals can also look like having some grilled chicken, whole grain pasta with some tomato sauce, and half a plate of just kind of mixed vegetables. You could do some coleslaw, some salad, or even some sliced vegetables. Balanced meals can also look like some kind of rice with tomato sauce, stewed greens, and some grilled lean meat. And balanced meals can also look like having about 1/4 of your plate be dal, or perhaps like a curried chicken, half a plate of maybe some okra or some other cooked vegetables. And this one has rice as well. Same thing, about 1 to 2 fists, or you could have another carbohydrate there as well. So we'll quickly review healthy snacks, and I'll just provide some examples. But as I mentioned, we want to have snacks between meals, and we want snacks to also include a source of carbohydrate, but we don't want to have that carbohydrate alone. So with your carb, you also want to include a protein and or a fat. So we'll look at some smaller snack examples. So you can see someone maybe had some nuts with some fruit, cottage cheese, which is high in protein with fruit, whole grain crackers, so those could be like Brie crisps, like a Wassa cracker, and some cheese, or even a small bowl of popcorn or air pop popcorn with some fruit could be an example of a smaller snack. And then we have a larger snack here as well. So you can see some yogurt with some nuts, hard-boiled egg with some crackers, bean salad, a glass of milk with some fruit are all ideas that can help keep you satisfied between meals. And finally, just quickly, we'll talk about healthy drinks. So our fluid needs do increase during pregnancy, up to 9 to 12 cups a day. We want most of that fluid to be water, cow's milk, or another fortified plant beverage like soy milk that has calcium and vitamin D most of the time. If you are having juice or a sugary drink, you want to limit it to no more than ½ cup per day, unless you have a low blood sugar. Some of those artificial sweeteners are safe during pregnancy. If you go to the clinic, you'll learn more. There's certain ones that are in the package that you don't want to use, but something like Crystal Light on occasion would totally be appropriate for that flavor. And then same thing, just try to get most of your fluid from water. So I do have a QR code on the screen, so I'll hold for about kind of 20 seconds before I stop sharing. That will take you to a PDF of a Alberta Health Services resource on healthy eating if you have gestational diabetes during pregnancy. And then definitely feel free to put any of your questions in the chat or the Q&A, and I'll do my best to answer them at the end, or just type a response as well.
Thank you so much, Emily. And apologies to everyone. We recognize we are going a bit over time, but we anticipate being done in the next 15 minutes. And we just want to make sure that we also have enough time at the end so that we can answer great questions that are coming in through the chat. And with that, I will introduce our last speakers. We've got 2 speakers in this next talk. First, we have Dr. Julianne Feng, who is a second-year resident in internal medicine at the University of Alberta with an interest in endocrinology and research in gestational diabetes. She completed medical school at the University of Toronto. Outside of medicine, she enjoys planning travel and is always preparing for her next trip. And joining her is Judy Feng, who is a second-year medical student at the University of Alberta, as well as a pharmacy alumni from the University of Toronto. Thank you.
Alrighty. Could you see my screen?
Yep.
Hi everyone, I'm Julianne. I'm presenting for our partner Judy. And today we're going to actually talk about a little project we did on research on how we can improve the care that we give, that healthcare providers provide for gestational diabetes. So, there's been a lot of work in gestational diabetes or GDM already, and we've talked about kind of what it is, some complications that can happen. We recognize that's a very emotional journey for a lot of people. But what there isn't a lot of is kind of tips or directions for clinicians on how to improve the care we provide people with GDM. So the question that we asked was, what changes do patients or their partners want to see in the care they receive for gestational diabetes? And what we did was we did a literature search. So we searched a lot of databases and we compiled and synthesized, findings from articles that, give insights on participants, what changes participants want to see in the care they receive, and their experience, the barriers and the enablers that they experience to manage the GDM. And we divided these into kind of two groups. And we'll start with kind of the changes that people with gestational diabetes want to see that they told the researchers directly.
Thank you, Julianne. So I'm going to start off by just diving into some of the patient-reported changes. A frequent need that was reported by the study participants is that they wanted to see more improvements in their diabetes education. Content-wise, people wanted more information on GDM. So that includes what it is, what causes it, and what are the possible consequences of GDM. People also wanted more clear and specific information on things like diet and meal planning, physical activities, and medications that they were given. So for example, I have a quote here that says, "I wanted to know more about what insulin was going to do. I knew what it was doing for me, but they couldn't tell me what it was doing to the baby. And I still don't know what it does." Showing just how more information and education on insulin, so things like its safety, its efficacy, maybe how to even inject insulin, things like that would be helpful. Okay, some more information and points were raised on education by the participants. Timing-wise, people also wanted to receive their education close to the time of their GDM diagnosis, and it was felt that this could help to decrease some of the alarm and anxiety that understandably came with the diagnosis. Participants also wanted to get more education in a flexible way. So instead of just the traditional in-person appointments, they also wanted to have options like maybe having a telephone appointment with their physician, having recorded classes available, or even being referred to trusted online resources. And finally, many mentioned that they would prefer their education to also include their family members. So for example, someone shared here that I have a problem with injecting insulin. If my husband could be taught, it'd be great help. If my husband knows my need, surely he can better support me. Showing just how useful it might be if there's support from family members and if they're actively engaged as well. And then the next point of improvement is that people would like to see more personalized care. One patient shared that whatever samples the diabetes in pregnancy clinic gave, it's all Canadian like bread, sandwiches, and the grilled foods, which I'm not used to. So then I have to change it to my things. I think if country-specific patterns, sample diets were created, that could be better. And I know that these sentiments were also shared with us by Hildy earlier on today in the presentations as well. So just overall, participants would want clinicians' care and their care decisions and recommendations to be really tailored and to consider things like cultural practices, language barriers, financial resources, and existing support systems. One other point, patient also expressed that they wanted more patient-centered care. So what this means is that they want their care to have greater flexibility. So for example, having those online methods available. They want the care to be more continuous. So this means seeing that one provider consistently throughout their journey. And they also want the care to have more compassion and attention. So for example, on clinicians' part, this could mean taking the time to actively listen to their patients and to answer any questions that may rise up. And just one quote here that really highlights the need for flexibility. Someone mentioned that it makes your life difficult. It makes your life, if you have a demanding job, very difficult, because I will have some weeks where I'm having an ultrasound Monday, I'm going to see the endocrinologist on Wednesday, and I'm seeing another doctor on Thursday. So I'm missing 3 days in a week. Just showing how in this situation, having that option to have flexible online appointments could be really, really helpful. And finally, some other points were brought up. Many mentioned wanting digital methods to help them manage their diabetes. So for example, using their digital methods to help keep track of and set reminders for blood sugars, to help with carb counting, and to maybe give some recommended exercises. Another key point that participants raised was they wanted more peer support. People wanted to be connected with others within their GDM community and to receive support in this really understandably emotional journey. So to do that, clinicians should also educate ourselves on existing GDM support groups and to also provide that information to patients. So that concludes the patient-reported directives. Now I'm going to pass it on to Julianne for some of our interpretations.
So in those studies, we did, there was a lot of information on kind of the lived experience of gestational diabetes and some of the barriers and enablers that people experience. And from that, we could interpret some further changes that patients want to see to really strengthen those enablers and try to mitigate those barriers. The first one being, as mentioned before, supports. And that could mean supports from their families, their partners, and also supports from the healthcare providers. I think patients or people with gestational diabetes wanted that for their clinicians to acknowledge the emotional impact of this kind of a diagnosis that they were experiencing and provide emotional support during their appointments. And as mentioned earlier by Judy, they wanted for education to be offered to their partners and their families to really help engage that support at home. For example, one participant had said, my husband will make sure I'm not taking too much sugar. He'll go and check online that what I'm having has the proper content of carbs in it, proper content of nutrition into it. So all these things that would have taken a lot of time for me, energy from me, and probably I would not have done. Another point that we recognize is that there can be a lot of stigma around gestational diabetes, either from society or from people's families or partners. And unfortunately, sometimes from healthcare providers as well. And patients had wanted their healthcare providers to acknowledge these experiences of stigma, and it's important for healthcare providers to also reflect on their own kind of perceived biases as well. So, one patient described, when my husband's family found out that I had diabetes, they kept telling me how unlucky I was to have diabetes. And at mealtimes, they say, you have diabetes, you should not eat this food, or you poor thing, you cannot eat this food. It really annoys me. It makes me feel more ill. So these are experiences that are really commonly shared with people with gestational diabetes that are not often acknowledged. So that would at least be a first step to addressing some of the stigma around this. And finally, it would be helpful for healthcare providers to acknowledge patients' specific motivations and concerns about managing diabetes. I think a lot of participants mentioned that one of their motivations was to optimize and try to improve their baby's health as well, and also reduce future risks to themselves and to their baby from the gestational diabetes. And really encouraging that would be very helpful for patients. Some barriers that people experience were, fear of needles, needle phobia. That's a very, very common and understandable fear. Or fear of having low blood sugars, especially when using insulin. And these are some barriers that people experience that made it harder to manage their gestational diabetes. So talking about these things specifically with the patients is something that can help them manage better. Yeah, so that kind of wraps up the talk that we have. Thank you very much. And just some questions to kind of consider and things we'd love to hear from you about.
Thank you so much. And at this time, I'll invite all the panelists to come back onto the screen. And Thank you so much, everybody, for your talks. And thank you to the attendees for sending in many questions. If you take a look at the chat, Dr. Yeung has posted a link to the evaluation form. This is the form that we kindly ask you to fill out to give us feedback on today's session, as well as where you would provide your email for the coffee card that we'll send out at some point this week. We do have to process the forms and then send out the coffee card, so it won't be an immediate send, but it will be sent to you this week. And with that, we'd like to answer some of the questions that are in the chat right now. The first one, Dr. Yeung, is for you. Can gestational diabetes be treated completely when using insulin during pregnancy?
Yeah, that's a bit of a tricky question, but thank you for the question. So gestational diabetes can be treated very well under the care of the medical team, as I mentioned, including nurse, dietitian, and doctor. There are cases where some people will just have a big baby because they have genes that predispose to a big baby. Like if you and your partner are 6'2", chances are your baby's going to be big, and it's not because of the gestational diabetes. So what I tell families is you just do your best, and we try to modify what we can. And we understand that we are trying to do what is in alignment with your values and with your ability and your resources. So there are some cases where the severity of diabetes is very significant, and it is hard to manage. And that's just a biological reality. And so we just have to work together. And if you're and I know most people are putting their best because they know that their baby's health is on the line. So I also want to acknowledge every one of you for coming today to learn more about your health. Thank you for showing up. Thank you for showing up for you and your families. That's really, really awesome. And the information is not meant to make people feel guilty about what has happened in the past, because all we can do is give you information and education that can serve you in the future. And just let go of what's happened. And we just have to take one step forward and just recognize where we're at now and try to make the best decisions we can moment to moment with what we have. So, but I can say that treatment and monitoring and doing the things that, we're asking families to do certainly goes a long way to protect the health of mom, to protect the health of baby. And I'm so glad to see there are some, at least from the names, there are some males in the audience, and I encourage you to take a supportive role and really do recognize how much pregnancy, having children, having gestational diabetes and diabetes affects, your partners and your families. And thank you for showing up there.
Thank you, Dr. Yeung. Before I go to the next question, Dr. Yeung, if you could just post the evaluation link again in the chat. It may have moved for some people, so it'll be posted once again in the chat for everybody. And in the meantime, another question that came up, I think this one's for me, is being active, like performing those physical activities, will it guarantee my baby not having bigger size? Similar to what was just said regarding insulin, it's not guaranteed, but certainly what the research has shown us is that if you are physically active throughout pregnancy, it does reduce your risk of baby being too large, and it does improve the likelihood that baby will be within the recommended range for weight. And the main thing is that with physical activity, as you're improving your blood flow, and your blood sugar levels, it reduces potentially the amount of sugar that's being sent over to baby. So that's how we're able to see that it could reduce your risk of baby being bigger size. Fortunately, we can't give you a guarantee, but certainly there's a lot of evidence to support that it will reduce the risk. And similar to what Dr. Yeung has said, the fact that you're here today and asking these questions as well shows that you really do want to improve your health and well-being for your baby, and that's so important. So doing what you can do is what's most important and what you should focus on. So I don't know, maybe Dr. Feng, if you want to take this next one, does gestational diabetes cause your baby to be overweight in the uterus, and could it lead to something like choking with the umbilical cord? Maybe Dr. Yeung and Dr. Feng, if you wanted to try to answer that one.
Do you want me to take that one?
Sure.
Okay. So, the reasons there is an increased risk if gestational diabetes is not managed that the baby could pass away in the uterus. That's called a stillbirth. And the reasons for that may sometimes be due to possibly getting big and having difficulties with the cord, but that is exceedingly rare and only in extreme circumstances. So most women with gestational diabetes go on to have healthy pregnancies and healthy children, the vast majority, okay? So it really is people who aren't able to access care for whatever reason. These are the conditions that we worry about. But if you are following along with your healthcare team and you're getting regular monitoring and you're doing those things, that should not be as much of a concern. And then as well, if there is a concern, women are monitored very, very closely. At the end of pregnancy, if the diabetes is, showing very high sugars, women are getting testing every week with an ultrasound. And then the obstetrician on top of that is making sure they have the right plan to get the baby safely out. And they're not going to keep the baby in there longer than they need to if there are risks to the baby or the mom. So I really encourage you to have trust in your obstetrician or your obstetrical provider that they're doing the best for you. And if they are suggesting things like C-section, there's a good reason for that. People aren't just willy-nilly suggested to do C-section. So that should be taken seriously. But generally speaking, the anxiety around something happening with the cord, that is an extreme and a rare situation, thankfully.
Thank you. And then the next question that we have, again, I think maybe Emily or Dr. Yeung, if you want to both chime in for this one. Apart from exercise and healthy eating, is there anything else that should be done or can be done to manage the situation?
Yeah, please, Emily.
Yeah, so I'll acknowledge that this is not my area of expertise, but when I talk to females that have gestational diabetes, I really encourage social support and social connection, and trying to find ways to talk to people that you trust about what you're going through. I think Hildy mentioned earlier that there can be some internalized shame and stigma. So the more that we are able to verbalize what we're feeling, I think the easier it is to kind of let those feelings go free, and then connecting with stress management as well. So I do need to go through Dr. Rose's website, but I know that anytime I review some material, stress management is always in there. So if you can find some techniques, whether that be deep breathing or other ways that you find can help manage your stress, we know that that has an impact on our blood sugars for sure.
And I also wanted to add that Dr. Yeung had brought up breastfeeding and prenatal colostrum expression, and that's a great resource and a great practice to consider. If there's no reason for you not to do that, to help with preventing a risk of future type 2 diabetes. Yeah.
Awesome. And I think we'll have time for just 2 more questions. So I have one for Dr. Yeung and then one that Hildy answered previously, but I think might be a good question to wrap up the session. So Dr. Yeung, what are the chances that once I give birth, I won't be diagnosed with and I think just diabetes. So once they've given birth, what are the chances that they wouldn't have diabetes?
Okay, so it's true. I didn't talk about sort of what happens at the end of pregnancy. So once the placenta is delivered, and it was the placental hormones that were largely driving the high blood sugars during pregnancy, the blood sugar levels actually drop to normal fairly quickly in most people. I'm talking about minutes to hours, okay? So if, for example, you were using insulin and had high blood sugars during pregnancy, within minutes to hours of having your placenta delivered and your baby delivered, your blood sugars should go back to what they were pre-pregnancy. However, I will caution that unfortunately, we are seeing a rise in pre-diabetes in our population, particularly in our young people, in young women and men. And so what we need to be aware of is that that's the importance of doing the post delivery testing. So some things I tell people are, you can keep testing at home with the strips that you have and check to see whether your numbers are still in line without medication or doing anything. And if they are, that's less worrisome, but be sure to complete the testing, the sugar drink test, as I mentioned. And what we see is that in about the first 18 months, 5 to 10% of people will convert to type 2 diabetes. But I think that it's largely because many of these people never had diabetes testing prior to pregnancy, and they probably did have prediabetes or pre-existing type 2 diabetes that we're just finding during pregnancy. So it's not true diabetes in pregnancy just due to the hormones of pregnancy. It was pre-existing prediabetes or pre-existing type 2 diabetes that has just carried on. So it is important to pay attention to the sugars after delivery and to get that repeat testing. In Alberta, half of people with gestational diabetes are not going for repeat testing. And I know it's because it's an annoying test, but I'm just putting it out there to reinforce the importance of that. And sorry, and the other thing is, for people, what other things that they can do to help manage their health? I'm going to say sleep is another one that we miss and we don't talk about enough in clinic. If you're not getting, over 7 hours of sleep a night, that's something that you need to look at. And we know actually from the scientific literature and the medical literature, pregnant women need more sleep. And I know it's, a problem because so many pregnant women have congestion and reflux and nausea and things affecting sleep, but prioritizing enough sleep and rest is critical throughout the pregnancy. And that's something that does affect sugars a lot.
Thank you so much. And then finally, the last question for Hildy. Hildy, I know you answered it in the chat, but if you could speak to it. How did you, this person has shared that their friend also experienced guilt. How did you overcome that guilt? And yeah, if you could wrap us up with that question.
Thank you, Dr. Taniya. I don't think you ever really get over the guilt, but what you can do is to educate yourself some more. For example, just today, I learned from Dr. Yeung that there are certain things that I could have done after delivery. I didn't know that when I was pregnant with my daughter. I didn't know that breastfeeding could have helped. I didn't know that I was supposed to take successions of tests after delivery. I didn't know. So just keep educating yourself and be nice to yourself. Take it easy. This is nobody's fault. My daughter's autism will never go away. She will forever be autistic, but it's manageable. And just have faith and give yourself some grace. Give yourself some hope because it is nobody's fault. Thank you.
Thank you so much. And Rose, did you want to wrap it up?
Oh, well, I just want to say thank you. Thank you so much, Hildy. That's a really great message. And that is a message that I like to tell families in the clinic, is that it's manageable. It's something that, we have some way of having influence over, and people can live very healthy lives. And even if people do develop type 2 diabetes, people can live very healthy lives. It's about just having, paying attention to your health, following along with the medical team, and doing what you can to protect yourself and your family. And I always say, try to make your home a healthy environment. So if there's a lot of temptations at home, try to clear it out. Try to make home a healthy place. Try not to buy the 5-kilogram bag of potato chips, and maybe just get the smaller one so that you don't have 5 kilograms of it sitting in your pantry. But anyway, and a last message, if anyone does want to see our live session, if they're in Edmonton next Sunday, we will be having an event. The speakers we're all going to be live. It's going to be the same information, but if you want it again live, you can register, and it's the same registration link as before. And the event will be next Sunday at the Edmonton Intercultural Center, registration at 10 o'clock, and then lunch will be served. We are capping registration on that because there are just so many spots. But if you would like to join us live for a conversation, we'd be thrilled to see you in person. And thank you so much. And thanks again to CIHR for funding this cafe. Take care, everybody. Be well.